Here we have a 35-year-old patient, and you will see these are like borders of the heart as a result of percussion that is being stated in this question. But you notice something here. Auscultation revealed atrial fibrillation, loud apical forced sound. If you are hearing a loud apical forced sound, definitely you think of mitral valve or any of the atrioventricular valves. And then we have the upper border is at the inferior margin of the first strip. This symbolizes atrial enlargement or hypertrophy of the atrium. Atrial enlargement normally supposed to be around the third rib. So what disease of the heart are we supposed to think of after echocardioscopy has revealed abnormal pattern of mitral valve motion? So this is already a very simple question by the endoscopy result. So we are thinking of either mitral valve prolapse or mitral stenosis, but it is mitral stenosis that will produce loud apical forced sound together with such hypertrophy. Secondly, we have if you read through this question, you will just come to one conclusion. This is a patient that has been suffering from syphilis, and now we have a neurological deficit. So this is neurosyphilis, and neurosyphilis can cause total dementia. Korsakoff's or amnestic syndrome here is usually associated with alcohol or thiamine deficiency in the so-called Wernicke-Korsakoff syndrome. Then we have lacunar dynestic dementia. This is usually a result of stroke, but in neurosyphilis it is a total dementia. Okay, we have a 47-year-old patient who is feeling heaviness over his entire body, considers himself good for nothing, is depressed. The only thing you can just think of is that somebody is really depressed. So it's a major depressive disorder. When we get to the pediatric section, hopefully we will be able to discuss about this infectious disease properly. But I want to point your attention to something here. This is looking like influenza, like adenoviral infection, and so on. But this particular patient is having vomiting at the peak of headache. This is usually characteristic of an increase in intracranial pressure, and which could be as a result of cerebral edema. So just based on this, the best possible thing to think of here is this answer with cerebral edema manifestation. So please, I want you to pay very close attention to this particular question, because we can have about 3 different correct answers depending on the state of the patient. Given the history of substernal pain, is squaring substernal pain 2 hours ago, irradiating to the left shoulder, don't forget, definitely the heart is being affected in this condition, and varicose vein of the left shin. The first thing you want to think about is this is an emboli, and you're thinking of pulmonary embolism. But you cannot choose pulmonary arterial embolism because the patient is first in shock and there's already a cardiac disorder. So we can have deep vein thrombosis progressing to pulmonary arterial thromboembolism and thereafter causing the so-called cor pulmonale, that is the failure of the right ventricle as a result of increase in pulmonary pressure, that is pulmonary hypertension. So in this particular patient, there is shock here, and the cause of this shock is heart failure, which we can invariably call the cardiogenic shock. So when you see varicose vein, think of deep vein thrombosis, but read further in this patient, it's called that the heart is directly affected. Okay, we have a 64-year-old patient, severe pain in the right side of chest, lags behind during breathing. Percussion reveals tympanic sound. So like I said earlier, dullness will point your attention to things that have to do with consolidation in the lungs or thickening of the lungs. Also, when you have fluid like maybe blood, pus, or whatever, it will cause dullness in the lungs. But when you have tympanic sound means hyperresonance. That is, you can hear like sound of more air. So you think of something like air in the lungs. So percussion reveals tympanic sound. So what can we actually suspect in this particular patient? Right-sided pneumothorax is best. This hydrothorax is going to cause dullness. This pleuropneumonia is going to cause dullness, pleurisy dullness. PATE, I think here it should mean pulmonary artery thromboembolism, but it's not in this case. So we have right-sided pneumothorax, that is air in the thorax. Okay, this substantiates just the previous question I was trying to explain to us. And we have the same complaint of heaviness and chest pain. Patient had chest trauma like 4 days ago, and there's something associated with this trauma. The red blood cell of the patient is low, so you are seeing anemia. So what could cause anemia in a patient that is having like a pulmonary disorder? And palpation reveals dull sound on the right. So I told you dull sound could be fluid or whatever, but since we are having anemia as a result of this, you are thinking of the blood is definitely leaking somewhere inside the patient. So that is an hemorrhagic punctate caused by the trauma. Okay, a 55-year-old man actually drowned. That's the basic thing. He drowned in a water body. Resuscitation measures allowed to save the patient. What complications may develop in the near future? A patient that's drowned will definitely have water in his system, and they want to hide somewhere, probably in the lungs. So pulmonary edema. So 18-year-old patient suffers from bleeding disorder after minor injuries, and this is occasional hemarthrosis, bleeding into the joints. So you are thinking of hemophilia, like our first video. What laboratory test will confirm hemophilia or hemophilia A and hemophilic factor? A is a clotting factor. So what do you want to check for? You want to check for clotting time. Straightforward. Okay. This is a patient with periodic compressing heart pain. Echo revealed thickening of the intraventricular septum in the basal part. Now, when you read the history of the patient together with this echocardioscopy result, you discover that the patient is suffering from hypertrophic cardiomyopathy, and it is genetic. Hypertrophic cardiomyopathy, and in this condition, since there is reduction in the left ventricular cavity, it is a concentric type of hypertrophic cardiomyopathy. What you want to do there is to reduce the contraction of the heart without invariably causing a reduction in blood pressure so much and so on. So the best possible thing to do here is to give a selective beta blocker to reduce this heart activity, which should be metoprolol. All beta blockers that begins with letter A to M, in most conditions, they are selective beta blockers. So we have history of a 40-year-old patient. Lumbar part of spine on physical examination is painful. On physical exertion rather is painful. So when you're thinking of lumbar part, this is looking like rheumatology. Pain in hip, joints, gluteal muscle hypertrophy. And then we have on the spine regenography, we have rib osteoporosis together with longitudinal ligament ossification. This is the baboon spine, which is an X-ray feature of ankylosing spondylitis. So that's the correct answer. You can see also spondyloarthropathy with Retal disease. There's an infectious complication. Patient also is going to have conjunctivitis or uveitis. So the best answer is ankylosing spondylitis. So we have a 38-year-old patient Slate production done in 15 years, respiratory dyspnea, dry cough. The major thing is patient is suffering from asbestosis. This is pneumoconiosis. Pneumoconiosis, like occupational related form of respiratory disorder, and the best thing to do in suspicion of all these kind of cases is a chest X-ray. So thorax rentgenography, chest X-ray. A 37-year-old woman is having squeezing substernal pain on physical exertion. Blood pressure is relatively normal. This is normal. Heart borders are dilated to the left. Aortic systolic murmur, ECG signs of left ventricular hypertrophy. What method of examination is the most informative? Please take note of this, and you see it in many questions. Most likely you have something like this in the exam. After ECG results in cardiac pathologies, the next thing is echocardiography. 99.9% of the times you will not be wrong, because you want to check the valves and other functions or anatomical defects of the heart. So we have 58-year-old patient had been in the hospital for 2 weeks based on treatment of osteoarthritis. Now you could see from all the other history that patient is actually recovering well. So what do you do? Why should I keep the patient in the hospital? So we administer outpatient treatment. Okay, we have history of a patient with bronchial asthma, not very severe, and we just want to know how to go about giving some prophylaxis for this patient. So this sounds so much like echinacea drugs, but the correct answer in this case is Interlum. Interlum and Barotec, however, they cause relaxation of the smooth muscle of the bronchus. But the correct answer is Interlum. Please just keep it at the back of your mind. Okay. 42-year-old patient applied to the hospital with complaint of pain behind the sternum. Now you will notice something, that the pain appears during significant physical work and lasts for 5 to 10 minutes, which is relieved by rest. So IHD in all these options is ischemic heart disease, and in this patient is just over 3 weeks. This is the first time in which the patient is going to be diagnosed of it. So, and it is an it is a stable form of angina pectoris because it is relieved by rest, or they didn't give us history of nitroglycerin anyway. So the correct answer here is ischemic heart disease, first established angina pectoris, relieved by rest. So we have a 19-year-old patient, and just like we discussed earlier, there are multiple injection marks on the elbow bent skin. One thing you want to think of is that this patient is an IV drug user, So whether the patient is swearing to an oath or whatever, as a doctor, you need to exclude HIV, you need to exclude syphilis, you need to exclude hepatitis. So ELISA for HIV. We have a 25-year-old female patient. I'm sure many of us are familiar right now with taste disorder. When you see taste disorder together with signs of anemia like weakness, sleepiness, blackout, dizziness, you are thinking of something that has to do with iron. And the patient is having menorrhagia. There's excessive bleeding during menstruation, and when there's excessive bleeding, the anemia is not going to occur just at once. Just because a lady is bleeding too much on her menstruation or during the menstrual period does not mean she's going to develop anemia instantaneously. Color index of 0.75, normal is 0.9 to 1 or 1.1. Some text will tell you 0.85. However, whenever the color index is low, please think of iron deficiency. Hemoglobin also is 70, very low. So this patient is having anemia as a result of menorrhagia. So it is either acute post-hemorrhagic anemia or chronic. So how do we know it's chronic? From the history. This will not cause and acute anemia is definitely chronic. We have a patient here from, if you read the question, I want to encourage us to always pause the video to read the questions. So please take note of these particular symptoms. In this particular condition, the answer is botulism. However, they are not telling us that the food is canned or tin kind of food, but we have double vision, and isochoria, flaccid swallowing, and all these things that can cause muscular relaxation is typical for botulism. You can ask the ladies, for those that use Botox to look more beautiful. So we have a 72-year-old patient, and I want to say something very important here. Always ask yourself that why are they giving me this particular information? Secondly, the simple answers are usually more correct, so don't think too far. So we have a patient that is had undergone a surgical operation, cholecystectomy, and the patient was prescribed gentamicin and cephalothane, first generation cephalosporin. So urine tests are without pathology and so on, but you can see that the creatinine here is elevated. Definitely the renal function is being impaired. Normal creatinine is supposed to be up to 106 micromole. So there is something causing this toxicity to the kidneys here, and that is gentamicin. Gentamicin is an aminoglycoside. It is autotoxic, that is to the air. It is nephrotoxic, and it is cardiotoxic. So it's nephrotoxicity of gentamicin. It is not glomerulonephritis, because the accumulator is this drug. Okay, we have GI pathology here. Patient is having jaundice, right, subcostal area. So you are thinking of something that's to do with gallbladder, liver, and alkaline phosphatase 2.0 hour per liter. Now, in this particular unit, the norm of alkaline phosphatase is 0.5 to 1.3 millimole hour liter. So it is elevated, and alkaline phosphatase is secreted by the epithelium of the biliary ducts. So you are thinking in this particular condition that the leading syndrome is not cytolytic. If it is cytolytic, they will tell us about ASAT and ALAT, but here it is a cholestatic syndrome. Cholestasis, that is a mechanical, it could be a mechanical disorder. So we have accumulation of the byproducts. So we have 55-year-old patient treated as surgical impairment for thrombophlebitis. On the 7th day, patient is having pain in the left part of chest, dyspnea, and cough. Again, thrombophlebitis, deep vein thrombosis, and so on. We are thinking of an emboli, thromboembolism. Now, whenever you see ECG phenomenon of S1Q3, here they are putting it Q3S1, but S1Q3 is very typical for pulmonary embolism, together with other things that you have a shock and so on. So this pulmonary embolism. I will take this question to just be an English exam. 51-year-old patient, factory worker. She complained of frequent headaches and so on. But why are they telling us about the noise level? The noise level has exceeded maximum allowable concentration. Even though she's hypertensive, but that is not what we are talking about here. This is a noise disease. Okay, I hope I have somebody studying a Crimea or who transfer from Crimea seeing this particular video. Patient undergoes a course of treatment due to chronic glomerulonephritis. The treatment was successful. Normalization of all characteristics was recorded. Sanitary could be recommended like where. So Crimea is a beautiful place to be. Okay, I want to say something here. Wasp bites. See, when you see manifestation as a result of bites, yeah, but in this particular case, there is no sign of shock. If it is anaphylactic shock, you might want to give adrenaline, but these are not signs of shock anyway. These are signs of, though we have like immune reaction, but the best thing to give in such condition is prednisolone. You will see this kind of questions over and over again, but in my mind, if it is not anaphylactic shock, I will not go for adrenaline. I would rather choose prednisolone. So we have vaccination by DTP, diphtheria, tetanus, and pertussis, and as a result of the vaccination, there are immune reactions. So what is the purpose of this vaccination is to create antibodies. So the antibodies definitely will bind with antigens, and when we have formation of immune complexes, we can have like some things called serum sicknesses. So these are things like serum sicknesses. If I remember, I think it's type 3 reaction. So the major cause here as a result of this vaccination is an immune complex. Immune complex. That's what is affecting the joints. We have a 29-year-old patient, edema 2 weeks after recovering from angina, and you would notice blood pressure is elevated, but since the kidney is affected, you are not thinking of choosing essential hypertension as your answer here. So hypertension here might be secondary hypertension. We have erythrocyte, we have protein more than 3.0, so you are thinking of nephritic syndrome because there's hematuria. That is acute glomerulonephritis. See, 2 weeks ago, post-streptococcal glomerulonephritis. Now, you can probably revise the New York Functional Classification of heart diseases, angina pectoris specifically, and you will discover that if they are giving the history of a patient, irrespective of all these other data written here, that they said a day while walking for 100 to 150 meters. So if a patient is having difficulty walking 100 to 150 meters, then you are thinking of class 3 of the functional classification, but it is stable because it will be reversed by nitroglycerin. So we have stable functional classification 3 of stenocardia. So if it is relieved at rest, it is you are thinking of 2, and thus in severe activities. In functional type 1, there's cardiac pathology, but there's no manifestation of symptoms even when patient performs severe activities. And in type 4, you will discover that even at rest, symptoms still continue. Alright, we have a patient with stomach ache arising 1.5 to 2 hours after meal. The most important thing is that we are having it an hour to 2 after meal and at night. I'm sure you are thinking right now of duodenum, and abdominal release epigastric pain on the right. So I think that is where you have your duodenum as well. So that was much of our time, this duodenal ulcer. We have a patient with right subcostal dull pain, and appetite has been declining, notice over 6 months. Weight loss. Whenever there's weight loss, I think of cancer except otherwise. And there's only one way for me to confirm that in a patient that is having history of gastric peptic ulcer, it is by having a biopsy. So what method of investigation will be most useful when you suspect a cancerous condition? Please do biopsy. Forget about every other option. You can read this history of infectious disease, but there's one reason I will advise you not to go to Siberia in this period when you are preparing for your Krok, is to avoid tick-borne encephalitis. And whenever they are telling you about a region, one of the first things I try to think about is that there is a vector-borne disease. There is a vector-borne disease. So that will help me to narrow down my answer, but specifically it's tick-borne encephalitis. You can see meningeal signs and everything. So we have 37-year-old patient, right epigastric or sudden acute pain in the right epigastric area after having fatty food. What method of investigation will you employ? So since it's associated with fatty food, I'm thinking of my gallbladder. So this is not musculoskeletal, as we said in our previous video. So if it is your gallbladder, people do it almost every time you do an ultrasonic examination. Check for the stones. 68-year-old patient, are thinking of some pains, enlargement of cervical axillary lymph node, you are thinking of cancers, lymphocytes 60%, that's high, white blood cell 35. Or I think you have some extra here to give to patients that have low white blood cells. Botkin, Crumpet's bodies, you are thinking of a condition of lympholicosis together with this data. So the correct answer, yes, can exclude all these other ones, chronic lympholicosis. The 38-year-old patient is having polyneuritic syndrome. At the back of my mind, I just keep it as polyneuritis. Peripheral nerves are affected. How can I, and with considerable loss of weight? So there's a pathology affecting maybe nerve and peripheral nerves. It might be a cancerous condition or whatever, but also in this particular kind of investigation where there's weight loss, I want to do histological examination under any condition. So that's a muscular biopsy with histological investigation of the material. The material there is the muscle that be taken. We have 30-year-old patient suffering from pain in the sacrum and coxofemoral joints, like the hip joints. You can see painfulness in the lumbar spine for a year. Ankylosing spondylitis is associated with HLA-B27 antigen. It's so nice to see it in the question. And one of the major features, even under the classification, is bilateral sacroiliitis. So this question is straightforward. Ankylosing spondylitis, bilateral sacroiliitis. All right, we have hypertensive patients also on the background of a renal disorder. How do you know? There's daily loss of protein. So when you're having proteinuria, it's very common. It's one of the very common questions in internal or in Ukraine. You're having proteinuria in an hypertensive patient, the best drug to use is an ACE inhibitor, angiotensin converting enzyme inhibitor. Please don't forget that also in clinical practice. 26-year-old male patient with post-operative hypothyroidism. Very simple. Something is low, you increase it. So they started giving the patient thyroxine. And now, patient is developing signs and symptoms of hyperthyroidism as a sort of the drug intake. So what do? You reduce it. So it's very simple to decrease thyroxine dosage. Here we have normal parameters of almost everything. Yet patient is having out of hospital pneumonia. So this patient just needs to be under supervision. I don't know what work the patient is doing. I don't know what condition might possibly be causing the intensification of pulmonary picture to the right in the lower lobe. So this kind of patient, according to protocol, should be observed over a period of 12 months. That is, you observe the patient for 1 year. After a tuberculin Martel's test, a patient developed hyperrhagia or hyperrhagic reaction. The patient developed hyperrhagia. What signs determine the hyperrhagic test in this adolescent? From class, is supposed to be 17 millimeters or greater than 17 millimeters, but we don't have that in this option. But a condition more severe is appearing here, which is necrosis. So this is the correct answer. At first, I was thinking it should be one of these higher figures, greater than 17, but no, we have necrosis here. That's the correct answer. So we have a patient who is a miner, and according to the answer and the history in this patient, one of the things we are thinking is a coal miner. It's mining coal. So we have free silica, 15%. So the other component of this remaining 15% is believed to be anthracosis, but it's combined together with silica powder, and that will give us anthracosilicosis. Please don't confuse it with anthracosilicatosis. It is anthracosilicosis. Anthracosis, anthracite means coal. Alright, we have a patient with pathological lump right inguinal region. Most likely this kind of question will come as an exam, but please notice it is medial. It is near the medial part of proper ligament. This is inguinal ligament, and also inward from the spermatic cord. Based on these two information, and we just know that it is a direct form of inguinal hernia. So the question is right. Okay, right-sided direct inguinal hernia. Okay, this particular patient have been operated on peptic ulcer of the stomach, weight loss of 10 kg, level of glucose on empty stomach, you could assume as fasting, is 6.7 millimole. That's high, and also after me 11.1. But the most important thing here is the fact that they told us about HA1C. This is a retrospective marker in monitoring the treatment of patient with diabetes mellitus over 120-day period or 3 months. So for patients who have HbA1c 10%, which is over 3 months, so definitely this is not a patient that is probably pre-diabetes, a patient that has been diagnosed of diabetes mellitus. So I was supposed to add the norm is up to 6.1 HbA1c rather. So we have a 52-year-old woman complaining of weakness, painful itching after washing and bathing, sensation of heaviness in the head. Notice hyperemia of the face together with hypertension, arterial hypertension. Spleen is 4 centimeters below the rib cage. So what is the spleen doing in this particular question? That excludes many of these answers and leave us to only one thing. Erythemia here is the same thing as polycythemia. So we have excessive production of red blood cell and also increase in blood volume, which is what is going to cause the hyperemia, the blood volume, the erythrocythemia causing hyperemia, the blood volume also causing increase in blood pressure. So you just want to think of polycythemia. Our spleen is trying to do a lot to take those blood out of the circulation. So we have splenomegaly. So it's straightforward, we have erythemia. Alright, this is similar to a question we had before. You can see that skin is gray and moist in a patient that needs resuscitation, and there is an ammonia odor in the air. If you see ammonia in the air, look at somebody around who is releasing that ammonia to the air, and that person is having problem with excess urea in the blood. That is uremic coma. Again, you can read through the question. This is a cardiology case, and once the patient, again, when they give you the ECG and every other thing, what method of investigation is necessary to do to determine diagnosis? Echo is never wrong. In 99% of the time. A 55-year-old patient complains of distended abdomen and rumbling, increased wind evacuation. So some fermentative processes are going on there. So some some of your classmates that do disturb you with some kind of sour smell coming out of their lower parts in class, silently or loudly, they're having some fermentative processes in them, and this is just the syndrome of fermentative dyspepsia. Syndrome of fermentative dyspepsia. If it's malabsorption, they will give us some other history. If it is fatty dyspepsia, they will tell us not just daily products, we talk about fat consumption and other things. We have 54-year-old patients over 20 years of age having femoral osteomyelitis. This is something very bad for somebody to have for over a period of 20 years. These kind of conditions will affect the immune system, will cause the body to produce certain kinds of abnormal proteins, and in this condition they are amyloid proteins, and amyloid proteins could spread to the kidneys and to the heart especially, causing a condition of amyloidosis. But you notice that there's proteinuria 6.6. That's so much. Hyperbulimia, because the patient is simply losing protein. So this is secondary renal amyloidosis. Secondary renal amyloidosis. Please don't. It's not acute glomerulonephritis. It's not chronic glomerulonephritis because of the femoral osteomyelitis and the history. And this immune system is affected. Okay, we have diphtheria, different outbursts in families over 3 years. What's the best thing to reduce morbidity rates? Morbidity is talking about the disease rate. It's different from mortality. It's to reduce the morbidity rate to single cases. What do? Immunize them. Simple. We have another patient in the water body. I don't know what they are looking for. The victim shows no vital signs. But the best thing to do in this patient is to release the respiratory tract from water, to create a drain position, that is by the posture of the patient, and to take on measures to restore respiration and blood circulation. That is the correct sequence. I am very familiar with this particular case in real life. So electro gas welding operator, you will notice that they always use dark glasses. And why are they trying to use dark glasses? It's just to prevent photoelectric ophthalmia. Okay, we can read through this and something is coming to your mind, diphtheria. But there's something that is missing in the question that I think most of us might have kept at the back of our mind, that diphtheria is difficult to separate. But coated with is also gray, with gray patch, which spread to jugular and frontal palatine arcades. So it's still diphtheria, laryngeal diphtheria. In Vincent angina, there are going to be ulcerations and other things. Okay, we have a patient here who, 48-year-old patient, complains constant pain in the upper abdomen. We have diarrhea, weight loss. Patient is an alcohol abuser. So patient refused to stop alcohol. Right now, alcohol is about to stop the patient. So we have 2 years ago, he had acute pancreatitis. But what's the major condition? You can see that the glucose level is elevated. Amylase level is decreased in this amylase level is decreased in this particular patient. I'm trying to remember the normal level of amylase, but it's supposed to be from 12 or so, but it's supposed to be greater than 4, but it is low here. So it means that we're having pancreatic insufficiency. And what do? You give a drug that will probably contain those pancreatic enzymes. Here the correct answer is pyrenzynum forte. Contrical will be used in condition of acute pancreatitis, so please don't confuse the two together. Pyrenzynum forte. We have interesting patient here who is having transmural infection. This acute transmural infection, this must be really painful for the patient. Patient is developing shock. Respiratory rate is 30 per minute, and the patient right now is presenting with moisture in lower parts of the lungs because the heart is failing, and like moisturizer means pulmonary edema. So what do you want to do? You want to give the drug, like the patient, a drug that can reduce pain and a drug that can actually try to reverse pulmonary edema. And one of those drugs which is missing in the option here is morphine, but we have promedol in the option. Promedol is half effective as morphine. Is an opioid analgesic. It will try to relieve patient of pain and also try to reverse pulmonary edema. That is why it is given in the very first place, promedol. We have 62-year-old patient here who is going into shock. Actually, it's 1.6, but most people are going to shock. We have retrosternal pain, which cannot be relieved by nitroglycerin. How would you explain the arterial pressure drop? Definitely, the patient, since the patient is having continuous attack of retrosternal pain, you're thinking of myocardial infarction because it cannot be released by nitroglycerin. So the best thing is that the heart is failing. When the heart is failing, it cannot pump out blood effectively to the circulation. We are talking about a reduction in the cardiac output. Okay. As you read through the question, you will just discover that the patient is having pain and other symptoms, other manifestation, but you cannot really find anything on investigation. ECGs show no pathology and so on and so forth. This patient is having somatization depression, and this is actually more common than we think in the population. It's been in the morning, and you can see that in the evening patient is getting better, so it's affected also by this season. All right, 18-year-old patient complains of pain in knee and ankle joints. Okay, this is appearing like migratory arthritis, and that is also somehow typical for rheumatic fever. So let's continue. We have fever, rheumatic fever, respiratory disease 1.5 weeks ago, swelling in and joint pulse. You can see patient is going to develop shock, heart border without changes, soft systolic apical murmur. You know that in the apex of the heart, you are looking forward to your mitral valve. The mitral valve is the most commonly affected valve in rheumatic fever, and patients have had respiratory disease 1.5 weeks ago. You are thinking of something that is as a sort of streptococcal infection, specifically streptococcus pyogenes, and one of the best tests to do there is to check the anti-streptolysin O level. This is the very last question in our first folder of internal medicine, the one with the first 100 questions. So, 30-year-old male patient who had been ill for 1.5 months, rash with pierced purpose covered with bloody crust on the abdomen, hips. All these cases, all this history, what really got my attention here is the fact that the purples are pierced. They are pierced. There are traces of line of scratches. I could remember the dermatology teacher saying scabies, that they like to go together, two. So the best thing to do there is to examine the rash elements scrape. You can see scratches, and that's really put our attention to this. So to check for Sarcoptes scabies. So we've come to the end of this. I think we'll go to the next folder. And some of the persons who have been enjoying the video as well is requesting for ups and gain. Hopefully we get there. So let's take it a step at a time. Success as you continue to prepare.